This is session 8 of the 12-session course that deals with maternal emergencies, maternal shock, maternal collapse, obstetric emergencies. And the sole aim of this course is to try and reduce maternal mortality. We are fighting for maternal lives. In this session, we will discuss resuscitation, and I will talk about resuscitation in details. Then we will have a summary, a small card that I need you to keep it in your pocket or to have it available in the labor ward where we fight, this is our arena. And actually, you can be fighting if you are working in a tertiary care center on daily basis. So you need this card with you all the time. This session is based on session 7, which we discussed during session 7, the fluids and the blood components. And while we are discussing the resuscitation steps are here. The 12 problems that you deal with. Of course, the resuscitation starts with the clearing of the airway, the positioning of the patient, warmth and avoid overwarmth, all the stuff that we are used to, A, B, C, D, whatever. After these basic steps, we need to replace the volume that is lost. Fluids are no replacement. We have to have this very clear in our minds. Fluids are no replacement. Fluids are resuscitation. What is the difference? I'm not replacing anything with fluids. The patient lost blood, she did not lose fluids. So losing blood means that I replace with blood. But I'm resuscitating physics. I am maintaining the volume in order to maintain the cardiac output. While I'm doing that, I know that crystalloids will only increase the volume by 1 liter if I give 3 liters crystalloids, which I will never do because the maximum crystalloids I am permitted to transfuse or to give to the patient are 2 liters. 2 liters will expand the volume by about 700 milliliters, and 2/3 of the crystalloids you are giving are lost either in tissue spaces or they come out in urine. Now this is a problem because if I give 2 liters, which expand the volume only 700 cc's, and I still don't have blood available, then I am forced to give colloids. So colloids, we agreed that the maximum colloids is 1.5 liters, on the condition that I have given already the 2 liters crystalloids, and so I am stuck. Colloids are better avoided, and crystalloids are better avoided. If you have blood components ready, forget about fluids. And once you have the blood components ready, packed RBCs, or fresh frozen plasma, stop the fluids and start replacing, because fluids are no replacement. So the first thing is I will give, once there is a shock eliciting event, the patient is okay, she's not deteriorated, I can start fluids and order a request for blood components. If the patient is deteriorated, then of course I have to give the crystalloids quickly and then give the colloids if I need till blood is available. And then blood comes. Blood, I replace blood on 2 steps. First step is to replace the volume. Initially, I have to replace the volume lost. And the second step is the fine-tuning, is the replenishing of the blood components. So the first step is I transfuse to replace the volume the patient lost. How do I know the volume of the blood lost by the patient? Either by clinical judgment, or there is visual blood, some of the blood which is lost, mixed or revealed. So I can see the towels, I can see the amount of blood which came out. Or best is the CVP. I have a central venous pressure inserted, so I know how much fluids this patient needs. To restore the CVP to normal, which is 5 to 10 centimeters water or 0 to 8 millimeters mercury. I do not use lab parameters while I'm doing volume replacement. Volume replacement is by clinical assessment. The problems that we discussed before in sessions 1 and 2 are that we always underestimate blood loss. The clinical condition of the patient, if she is totally normal, pulse is normal, systolic blood pressure normal, diastolic normal, no tachypnea, urine output is great. This patient, if there is a shock enlisting event, may have already lost 1 liter. If there is some tachycardia only, without hypotension, without anything, the systolic blood pressure is above 90, this patient had lost at least 1 liter and maybe 1.5 liters, maybe up to 1.5 liters. If I have hypotension, she lost more than 1.5 liters up to whatever, okay, whatever blood loss is there. So please don't be deceived by the clinical condition. And in the last slide, the card that I will give you, I'll give you a guide, how much to transfuse for every patient. Now, the transfusion, we don't transfuse, everybody transfuses whatever he likes. We have preset protocols, and we talked about this in the previous lecture. If the patient needs 3 liters or more, we give them as 6-4-1. 6 packed RBCs, 4 fresh frozen plasma, 1 platelet concentrate. If she lost about 2 liters, or you need to replace about 2 liters, give 4 packed RBCs, 4 fresh frozen plasma. If the loss is less than this, I don't need all this volume, then I will give 4 packed RBCs, 1 fresh frozen plasma. This is about 1.5 liter. 1.5 liter. If I need more, for every unit packed RBCs, I will give 1 unit plasma. So we start by 4 packed RBCs, 1 fresh frozen, and I then continue 1 packed, 1 fresh frozen, 1 packed, 1 fresh frozen, as much as I need. And this is suitable for low resource settings when I don't have that much fresh frozen plasma. I never give whole blood. This is obsolete, finished. So the mistakes here in resuscitation that will make the patient deteriorate, either you gave more than 2 liters crystalloids, you gave more than 1.5 liters colloids, or you transfused whole blood. Or you are transfusing packed RBCs without clotting factors at all. So all these are to be avoided. The second step in replacement is the lab guided replenishing of components. So first component I need to replenish is the hemoglobin. If the hemoglobin is less than 8 gram percent or the hematocrit less than 25%, then I use packed RBCs. I will use packed RBCs with the equation that every 1 unit packed RBC will increase the hemoglobin by 1% at 1 gram percent and the hematocrit by 3%. The next is platelets. If platelets are less than 75,000, I give platelet concentrate. 1 unit platelet concentrate per 10 kilogram of the patient's weight will increase platelets by 20 to 50,000. Then I need the blood to be clotting efficiently. So if the PT, PTT or INR are above 1.5 the normal, I need to bring them back below 1.5 normal by giving fresh frozen plasma. Every 1 unit fresh frozen plasma per 25 kilogram patient's weight will increase the clotting factors by 25%. Last but not least is the fibrinogen. I need fibrinogen more than 200 milligram percent. So if it's below 200 milligrams, I will give 1 unit cryoprecipitate per 10 kilograms patient's weight in order to increase the fibrinogen by 50 to 100 milligram percent. So this is the fluid resuscitation and the blood component replacement. We finished these two. Number 3 is the corticosteroids. Corticosteroids are very beneficial in a shock patient. They stabilize the membranes. They do a lot of things that we don't fully understand because they work on the cell membranes and they work on the cellular mechanisms. So they protect, I will just read for you, they protect against bacterial endotoxin, lethal effect, how we don't know. They increase the cardiac output and microcirculatory perfusion, which we know very little about. They interfere with endotoxin antibody complement reaction during sepsis, which is very important in septic shock. And they may decrease the myocardial depression, so they allow the myocardium to work more efficiently and protect against mucosal membrane and decrease the permeability. Now this is what corticosteroids do. So we need to give corticosteroids. I usually start corticosteroids very early in shock. If a patient is starting to have tachycardia, I will give corticosteroids. The guidelines will tell you that you should give corticosteroids as soon as diagnosis of septic shock. Of course, corticosteroids are mandatory in septic shock because septic shock is based on inflammatory reaction. So I need anti-inflammatory, a strong anti-inflammatory. That's why we will use corticosteroids in any septic shock. Or refractory hypovolemic shock. I don't have to wait till refractory. So what I do, I'm telling you what I do. What I do is that I give it early once there is tachycardia in order to help the patient maintain the perfusion through the mechanisms that we don't fully understand. And then if there is pulmonary insufficiency post-traumatic. That's why when you give them, it's better to continue for 24 hours, except in septic shock. In septic shock, you give it for 7 days. So we give usually hydrocortisone. You can give 50 milligrams every 6 hours or 200 milligrams by infusion or 200 to 300 milligrams divided in 3 to 4 doses daily for 7 days. In septic shock, you don't give one dose. You give for 7 days. In hypovolemic shock or whatever type of shock other than the septic, you can give one dose or you can continue for 24 hours. I usually continue for 24 hours after, yes, after what? Yes? After controlling shock. I needed a good answer from you. If you have seen the 7 sessions, then you should have answered that 24 hours after controlling shock state. And how do we control shock state? If anybody doesn't put the right answer, you have to see the sessions again from 1 to 7. By treatment of the cause, by stopping the cause. If it's preeclampsia, I have removed the placenta. If it is hemorrhage, I have arrested the bleeding. If it's postpartum and bleeding from the uterus, I remove the uterus. If it's sepsis and the septic focuses the uterus, I did hysterectomy, finished, خلاص. If it's sepsis and the problem or the infection is in the contents of the uterus, not the uterus itself, well, I have done evacuation and curettage. From the control of the shock state, we need corticosteroids for 24 hours. This will help your patient survive. Okay, so this is corticosteroids.
All lectures are based on Tocqueville textbook, your one-stop, postgraduate study source, and decision support platform. You have 14-day free full access trial. Follow the link in the description to start your trial. Remember to hit the subscribe button, and if you find this video useful, please like and share.
Next is lactic acidosis. And lactic acidosis marks the turn of events. When lactic acidosis happens, everything is turned against the patient, and everything escalates very quickly. Because lactic acid is very harmful to endothelial cells and endothelial cell function. So how do we know that the patient is in lactic acidosis? First, there is acidosis. Acidosis is pH less than 7.35. And to know that it is lactic, then we must have lactic acidemia. Lactic acidemia is when lactic acid is above normal. It's above 1 millimole per liter. But to cause acidosis, it has to exceed 2 millimoles per liter. So you have lactic acidemia from 1 to 2 millimoles per liter. This is like a final warning. This is you are stuck in the corner, and within very little time, the patient will move from lactic acidemia to lactic acidosis. With acidosis, pH is below 7.35 and base deficit. And to know that the respiratory element is not playing a major role, then the pressure, arterial carbon dioxide, should be less than 42 millimeters mercury. This is the definition of lactic acidosis. If the pH is less than 7.2, you have a mortality of about 50%. If it's less than 7, there was no survival. So this means that you have to act fast. What is the right action? We will see now how to treat acidosis. This is very important. Because acidosis will lead to endothelial cell dysfunction, will lead to vascular smooth muscle dysfunction, will lead to disruption in the organs, leading to multi-organ dysfunction and multi-organ death. It seems logical that when there is lactic acidosis, we give bicarbonate. Bicarbonate is the buffer. The Problem is that bicarbonate has been removed from all guidelines in the treatment of shock. Why? Because when you give bicarbonate will buffer the acid, which is the hydrogen ions, and it will form water and carbon dioxide. First thing is that there is a risk of overcorrection, but this is a trivial risk. I'm not so worried about this. The problem is in the rise of the carbon dioxide. Rise of carbon dioxide pressure means that I have increased the hemoglobin affinity for oxygen. The oxygen dissociation curve is shifted to the right with more sticking of oxygen to hemoglobin. So I will increase the hypoxia. The second thing is that the large generation of carbon dioxide, the carbon dioxide will enter the cells because carbon dioxide permeability is 200 times more than oxygen. So it diffuses into cells very easily. And this will lead to intracellular acidosis. So you decrease the extracellular acidosis, but you increase the intracellular acidosis. The other effect is that there is decrease in the extracellular hydrogen ions. So more calcium binds to albumin. And so I have another problem to deal with, which is the reduction in the ionized calcium. So giving bicarbonate disrupts a lot of things. It increases the intracellular acidosis, it increases the hypoxia, it decreases the ionized calcium, so I have to replace it because calcium stabilizes the cell membranes, especially in the heart. I may overcorrect the acidosis, and all this will lead to decrease in the cardiac function and will lead to more multi-organ dysfunction and multi-organ death. So bicarbonate is obsolete. We don't give bicarbonate. So what is the treatment of lactic acidosis? Actually, treatment of the cause of acidosis, which is the cause of shock. You have to treat the shock, not resuscitate. So we have to recognize and correct the underlying cause of shock. We have to provide adequate oxygen so tissues do not resort to anaerobic metabolism. And very important when we talk about oxygenation is the correction of anemia and the reduction of oxygen demand to tissues through sedation. And if I need to, I have to correct maintain adequate oxygenation by mechanical ventilation. This gives you an insight of how important it is to stop fits in a patient with eclampsia. Fits will increase the tissue demands, will decrease the oxygen supply, and will increase the acidosis. And I said acidosis is a very important enemy. It is a very strong player in the equation of survival and death of the patient. If I don't have, if the patient develops acidosis and I have to decrease the lactic acid, how do I decrease it? By dialysis. Dialysis, this is the only method. So acidosis, I have no treatment apart from treatment of the cause, and if I'm in a severely morbid patient, I will do dialysis to remove or to correct the acidosis. Now dealing with hyperkalemia. Hyperkalemia is defined as a potassium concentration more than 5.5 milliequivalents per liter. I don't have anything in the definition stating that clinical assessment or ECG changes or hemodynamic instability or whatever is a diagnosis. So it should never, hyperkalemia should never be diagnosed on clinical or ECG grounds. If the potassium level exceeds 6.5 milliequivalent per liter, then I have to give intravenous calcium gluconate in order to stabilize the action potential across the cell membranes. That's why we always electrolytes, we have to do potassium and to do the ionized calcium as well, because hypocalcemia is very important to treat. To decrease potassium level, we give short-acting insulin 10 international units together with 25 grams dextrose. This will decrease the potassium level by approximately 1 milliequivalent per liter within 20 to 30 minutes, and the effect lasts for about 4 to 6 hours. So if you need, you can re-request the potassium level investigation after 40 minutes to 1 hour. Sodium bicarbonate is the last resort. We do not give bicarbonate in shock, so it is never considered as a first line treatment. This is what we give to reduce the potassium level by 1 milli equivalent is 10 units from short-acting insulin with 25 grams dextrose. The next problem is the hypocalcemia. I have to target ionized calcium level 1.2 to 1.3 millimoles per liter. If I need to give calcium, I usually give calcium gluconate by very slow intravenous injection. Each vial of calcium gluconate 10% has 10 milliliters. This means that it has 100 milligrams per milliliter, and this means that in this vial, which will be given IV very slowly, contains 1 gram of calcium. In order to reach the target ionized calcium concentration, then I will need to re-request the ionized calcium serum ionized calcium investigation after I give this vial by about 10 minutes. Now, the next problem is the maintaining of adequate oxygenation. The adequate oxygenation, we talked a lot about the partial pressure or the pressure oxygen, arterial, and the saturation and the difference between them. What I need is to keep the pressure oxygen above 60 millimeters mercury and the saturation above 90%. So 91, 92, 93 up to the normal, which is 98 to 100%. How can I increase the oxygen delivery to tissues? The best thing is to correct anemia, because specifically every gram of hemoglobin carries 1.25 milliliters of oxygen when 90% saturated, which is the least saturation that I accept. By comparison, if you increase the oxygen content without increasing the hemoglobin percent from 100 to 200 millimeters mercury, this will lead to transport of only 0.1 milliliter of additional oxygen for each 100 milliliter of blood. So evidently, correction of anemia is the best method to improve oxygenation. Other methods, of course, mask ventilation up to mechanical ventilation. These are other methods. Now, DIC, disseminated intravascular coagulopathy, if it is present, what is the treatment of DIC? By the way, session 9, we will discuss in session 9 DIC in details. So if you don't understand this code, which is that the main strategy is to avoid the occurrence of DIC by early treatment of the cause, then you have to see session 9 to fully understand how to treat DIC professionally. So DIC, the only treatment available actually is treatment of the cause. And after treatment of the cause, you start replenishing the clotting factors and fibrinogen and platelets. But before treatment of the cause, you cannot do anything. There is no treatment. Before treatment of the cause, do not give replacement of clotting factors or fibrinogen, because the body will just take them, and with the trigger which is already present, thromboplastin or whatever, it will form new blood clots and they will be lysed. And all you have benefited is that you are increasing the FDPs, the fibrin degradation products, which are, by the way, anticoagulant, and by the way, they are also tocolytic, and so you are aggravating the whole condition. The only thing we do is that we treat the cause. Sometimes antifibrinolytics were recommended, but they are not anymore. They should not be used in our DIC. There are patients who have DIC because of increased fibrinolysis. Now these patients can benefit from the tranexamic acid or whatever the antifibrinolytic. But in our consumption coagulopathy, it's a consumption coagulopathy, antifibrinolytics are not recommended. So we are left with treatment of acidosis is treatment of the cause. Treatment of hypoxygenation is maintain adequate hemoglobin percent. Treatment of DIC is treatment of the cause. Now, other circulatory support is the vasopressors and the inotropes, and this is usually given by the anesthesiologist. Dobutamine is the best vasopressor to be used in shock, and it has to be individually adjusted. We use it as 250 milligrams per 50 milliliters syringe, and we use it as infusion, the infusion systems. The the dose is quite variable, and every patient needs a different dose, but usually patients respond to a dose of 2.5, 10 micrograms dopamine per kilogram per minute. And then the management of septic shock, I just put this so we finish septic shock within the 12 lectures, because we have discussed the pathophysiology, the difference between septic shock and other types of shock, and we discussed the definitions of infection, sepsis, severe sepsis, and septic shock, and how to diagnose each of them. The treatment of septic shock follows the exact same lines of treatment as any other type of shock, but we give some more attention to the blood pressure, because septic shock is a vasodilator, direct vasodilator by the toxins it produces. So always try to maintain the mean arterial blood pressure above 65 millimeters mercury. This is the least mean arterial blood pressure to maintain perfusion to all tissues. So we pay attention to this. We pay attention to the central venous pressure, because septic shock leads to leakage of fluid into the tissue spaces. So the patient is not losing blood, but she is losing volume. So we have always to maintain the volume, to maintain the central venous pressure at least 8 millimeters mercury. By the way, this is also my objective in any type of shock. But in septic shock, I have to watch these two parameters, the mean arterial blood pressure and the central venous pressure. The rest is just as any type of shock. And then we will go for organ support. For the lung, I have mechanical ventilation in my back pocket if I need to use it. I have for the kidney, the first thing is to give diuretics. When you have achieved volume replacement and you are no longer worried from the hypovolemia, you can use diuretics to force blood to go to the kidney, and this will lead to avoidance of necrosis, cortical necrosis or tubular necrosis. I'm not giving diuretics because I want the patient to lose the fluids I'm giving. No, I'm giving diuretics to push the blood to the renal circulation. And of course, if I have any signs of any marks of renal deterioration, I will go for dialysis. If the creatinine, urea, whatever are rising, then I will start dialysis. Dialysis can be, usually it's a temporary dialysis till everything normalizes and the kidney comes back to function. Sometimes it's permanent. Unfortunately, the kidney has underwent too much necrosis and cannot maintain the fluid balance. The liver, we use liver support strategies. The heart, we said we use inotropes and dopamine. And if there is maternal cardiac arrest, we'll do CPR. And CPR will be discussed in session 10. Now, the last two things are pain management. In cases of septic shock, don't give non-steroidal anti-inflammatory drugs. In cases of shock, usually I don't use morphine. I don't want anything which affects the CNS of the patient or causes CNS depression. So the best thing is pethidine. And if you need, you can give regional anesthesia, by the way, if you don't have bleeding tendency, of course. So everything is by its contraindications and indications, and you can read about it or know more about it in the pain control in obstetric patient. What are the contraindications of opioids, of non-steroidals, every type of pain management. And you have to guard against the infection, as we said, because in all types of shock there is tissue hypoxia and tissue ischemia. And as we said, the maternal immunity is reduced. So the mother is more prone to infection. So we have to give broad spectrum antibiotics. And you have to obey all infection control policies in the place you were for. This is a very important card. You have to print this card or make a copy of it and keep it in your pocket all the time, or keep it in the labor ward, as we said. Now this card has the following. These are the fluids that we use for resuscitation. Crystalloids, colloids, packed RBCs, fresh frozen plasma, and platelet concentrate. This is the hydrocortisone, this is the calcium gluconate, dextrose insulin, and others, pain control, antibiotics, ICU admission for mechanical ventilation or for dialysis. Here you have every set of observations. You have the time, you have the pulse, you have the systolic blood pressure, and there is an add mark here. Plus, if you did potassium, you write the potassium level. If you did ionized calcium, you write the ionized calcium level, and so on. And then at each time, what did you do? Here I gave the crystalloids, I gave 1 unit, and then I gave a second unit here, and then blood came, so I did not give, I gave from here, I started to give packed RBCs. I gave 1, I started at this certain time, and then another one, and then another one, and then later on down the card you can put when did you give fresh frozen plasma. Maybe I gave steroids here, maybe calcium gluconate I did not need except at this time, and if I need to go to ICU I'll put it here. So this is the card I wanted to be with you, so you know whatever thing you are giving at what time. You have to write here the shock event. What am I talking about? Postpartum hemorrhage, preeclampsia, antepartum what? And then the time it was diagnosed and the time it was controlled. The difference between these two, the time diagnosed and the time controlled, is the delay time. The life of the patient depends on this delay time. The longer the delay, the more mortalities you will have. The less the delay, the less mortalities you will have. The quick guide that I told you, if I have a pulse less than 90 and systolic blood pressure more than 90, this means that I need in the average of 1 liter. If the pulse is 91, just 1 beat more per minute, and the systolic blood pressure still above 90, I need at least 1 liter. At least 1 liter, and in the average of 1.5 liters. If the pulse rises above 100 and the systolic blood pressure is less than 90, then I need at least 3 liters. If I go into hypotension, I need at least 3 liters. The precautions during resuscitation: do not underestimate blood loss. No crystalloids above 2 liters. Avoid colloids as much as you can. No whole blood replacement. No lab-guided initial volume replacement. Initial volume replacement is by clinical assessment, CVP, or by the estimation of the amount of blood the patient lost. No bicarbonate to correct acidosis. No hyperkalemia diagnosed by ECG or clinical signs. Now we have finished session 8, where we discussed resuscitation. Next session is session 9. We will talk about DIC, disseminated intravascular coagulopathy and coagulation, in details. So see you next session.